This is Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh. Brian, we are in a special place today.
Right.
In our hotel room, Brooklyn, New York, and we are with Dr. Chris Reilly, who is an emergency medicine physician here in Brooklyn. I'll let you do some introductions on how you guys met, and then Chris will have you do an introduction as well.
Absolutely. Yeah, hey, so Chris and I met actually while we were doing some stuff for Butterfly, the handheld ultrasound. And so we kind of connected, had a good time chatting, and so decided we'd come out to Brooklyn, which is where we are now, looking out our window at Brooklyn. And so, yeah, Chris and I, we did a little bit last night. We're going to continue some more stuff today, but getting the podcast going. Chris, you want to introduce yourself? Tell us a little bit about yourself.
Sure. So, again, I'm Chris Reilly. I'm an emergency medicine physician. I'm also, at the same time, as an attending physician in a medical education fellowship. And in emergency medicine, we have a lot of different quote-unquote fellowships, which are, we have our accredited fellowships like critical care, and there's actually a critical care / anesthesia accredited fellowship. But there's a lot of other fellowships that are not accredited. So one of them would be, let's say, mine, which is medical education. So medical education either has a 1-year fellowship or a 2-year fellowship. I'm in a 2-year fellowship, and that means they're basically sponsoring me for a master's in education. So I like education so much that I decided to take
extra time,
another 2 years and more school to continue that.
So why emergency medicine? That's question number one.
Sure.
And question number two is why the medical education fellowship after that?
Yeah. So both great questions. Emergency medicine was my first exposure to medicine in general, outside of, I feel like most people I talk to before they get into medicine, they're like, oh, I shadowed an orthopedic surgeon. Yeah. And I was an athlete in college, loved orthopedics. That was my first exposure to medicine technically, but my first job in medicine was as a scribe in the emergency department.
Nice. Okay.
And that was during a gap year prior to medical school. And during that gap year, I got to see some incredible personalities in the emergency department. Everybody's so laid back, very down to earth. There's no huge egos down there. And just,
as opposed to orthopedic surgery.
Well, I'm not saying anything. I'm not saying anything. I know you work with
a lot of them. A lot of orthopedic
just
surgeons.
A couple. Just
his favorites.
I love orthopedic.
Yeah, exactly. But so not the biggest egos, very kind people, and I really enjoyed seeing the spectrum of pathology, and anything could come through that door, whether it's a stubbed toe or somebody bleeding out from a stab wound, or it could be anything.
Yeah.
And that always made me so excited to go in and scribe, because I never knew what I was going to see that day, especially as someone who had barely any medical background before medical school.
Gotcha.
So it was pretty exciting stuff. And then I had a mentor who told me when I was in medical school doing clinical rotations, I know you were a scribe in the ER, but don't pigeonhole yourself to EM. Like, try to keep that open.
Look at
mind,
everything,
And I feel like that's such an important piece of advice for any medical students out there listening. Don't pigeonhole yourself into something. Really try to see yourself on every rotation going into it and being like, hey, I'm on this rotation right now. I am visualizing myself being an OBGYN, an anesthesia. Maybe not me.
Maybe not OBGYN.
I mean, we have to do that in the ER, but I couldn't do that every day of my life.
No.
But anesthesia.
Yeah.
Just try to see yourself in those roles when you're in those rotations, which is cool.
So did you enjoy the other rotations, or did you really just from the beginning? I mean, I know you kept an open mind, but did you from the beginning pretty much say, hey, ER was the one I really liked the best, or did every rotation? So I guess for me personally, I enjoyed a lot of the not every rotation, but I enjoyed a lot of the rotations, and so picking anesthesia made sense to me based on my background. But I liked a lot of the rotations. Did you like a lot of the rotations, or did you just really focus on emergency medicine?
Honestly, I think because I had that advice, I actually genuinely did enjoy each rotation. I found things from each specialty that I actually really enjoyed. I loved the procedural stuff. I loved, in general, all of the different types of pathology. And I think if I didn't have that, I probably would have kept a closed mind and just been like, this is stupid. I just want to get to the emergency medicine rotation.
Yeah.
So I thought that at the time, and I really think that helped me enjoy each rotation.
That's good. That's good advice. Yeah. I probably wasn't as open-minded as I should have been on some of the rotations, but I liked a lot of different ones. So. Okay, so that's why you chose emergency medicine. So tell us a little bit about why you chose the medical education path.
So medical education is something that has slowly shown itself to me in residency. You know, as a resident in the emergency department, especially, we get a lot of med student rotators and PA students, NP students, and they come through and they're so eager and excited to learn. And I really took it upon myself, like my second year of residency, to really focus on educating the medical students. And I always enjoyed how excited they would be, or be like, wow, that's like so incredible.
Yeah.
And just being able to see their reaction to getting that new information and seeing the effect it had on those people. And not only that, but in order to educate people, you have to know what you're talking about, right? So it forces you to really know your stuff.
Gotcha.
Because if you don't know your stuff, then you're just going to sound stupid, I guess, talking to them.
So the real question is, though, why not anesthesia?
So anesthesia and EM, we have a lot of crossover.
Yeah, lots
a lot
of
of
overlap,
crossover.
yeah.
And I think the biggest thing for me with not anesthesia was not only the background as a scribe, so I was used to that environment, but also in the emergency department, I feel like there's a camaraderie with not only, you know, fellow attendings kind of hanging out in residence or whatever, but also the nursing staff, the PCTs,
and your other attendings as well.
Exactly. Which is really nice, because you're just like, you know, if it's not busy, it's like 3 a.m. and everybody's hanging out. They call it the 3 a.m. test. Basically, if you're on a rotation as a medical student, can you stand this person at 3 a.m.? So I thought that was always really nice. And in anesthesia, it's like the OR environment, and it's kind of like,
you're very
don't talk to me. I'm the surgeon. Here's the
you're very isolated. That's true. That's a good point. That's a good point.
So that was kind of the reason, because I was on the border of both of those things. I really enjoyed anesthesia. I love airway management. I actually just gave a lecture to my residency program yesterday via Zoom on DSI and awake intubation, which was really cool.
Nice.
But you know, it's one of those things where you know it when you are experiencing it.
Yeah. All right. Fair enough.
Yeah.
So two questions for you. One, why medicine in general?
Sure.
I mean, was your dad a doctor? Was your mom a physician? I mean, why medicine?
So medicine in general, I have no one in my family on either side that's in medicine. I kind of just had to figure out things the hard way. I took 2 gap years. I applied to medical school 2 times, didn't get in to any U.S. MD schools. I didn't know about DO schools, so I didn't even apply to those. And then my parents had a friend who knew a doctor who's an emergency medicine physician who went to a Caribbean medical school, St. George's, which is where I ended up going to. And they kind of just told me, you know, it's kind of all on you. You're investing in yourself and in your future. So if you work hard enough and you want it bad enough, you can get the spot in the U.S. But I don't have any medical background.
Easier or harder to train in a Caribbean island?
So honestly,
that's a good question.
A lot of people talk about Caribbean as like, oh, you know, it's like Grenada was one of the most beautiful places I've ever lived in.
Yeah, we had a family friend that went to med school in Grenada, actually,
nice.
to that school.
It's beautiful. Yeah. I highly recommend everyone to go visit it for vacation. Fantastic people, fantastic culture. You do 2 years down there, so 2 years on the island doing all your basic sciences, and it's basically just you're stuck in a library all the time, right?
Yeah,
so
that's med school. Unfortunately, that's medical education basically everywhere.
Exactly. So it's in those first 2 years that you're like, all right, I'm stuck in the library all the time. But after exams, you got to explore the island.
Yeah.
Play on the beach.
Oh yeah, it was great. So I play guitar and I would sing, and I had a bunch of us that we would jam together at like a local bar after exams.
Yeah.
And man, some of those times were like my favorite times.
Nice.
But those 2 years we're down there, I would say it's pretty much like any other medical school. Just when you are not studying, it's a beautiful Caribbean island to hang out on.
So a lot different than Princeton, New Jersey, or where you're from, and practicing medicine in New York. Brian and I talk about all the time the differences between a big city and a rural community, a small town. Now, we were with a physician who was in L.A., and he kind of told us stories about the different cultures that he would see in the OR, celebrities, that sort of thing.
Although he said Minneapolis was crazier.
Yeah, when he was in Minneapolis, it was
crazier.
The trauma
than LA.
was crazier than it was in L.A. Number one, how is that in the hospital you're at, trauma, and then, comparing that to what might be a smaller community, even though you probably never, practice medicine in a smaller community. Like, what is it like being in a big city in Brooklyn, right in the heart of it?
So actually in residency, I was at a small community hospital, Brandon Hospital. It's in Brandon, Florida, in the Tampa Bay area.
Sure. Nice.
And we actually got to rotate around at different freestanding ERs in more rural critical access areas.
Okay.
And there is a huge difference between the two. That was a very busy hospital, but now I'm in Brooklyn. And our hospital is ridiculously busy.
Yeah.
And not only is it, ridiculously busy, but I will use the translator phone and hear 10 to 15 different languages a shift. So working in Brooklyn, there's so much cultural diversity. There's so much different presentations of pathology that I would never even think. Some patients are extremely stoic. Some are over the top and really in distress when they're in pain. I've had some patients that have ruptured hollow viscus in the abdomen that are completely
stoic,
nothing.
Yeah.
And I'm like shocked when I find these findings.
The CT scan shows
and
a
you're
bunch of stool in the belly.
How is this happening? So it's really interesting going from that community shop down in Florida where it's, similar presentation for the same kind of patients, and it's a smaller area, so patients may not have as much access. But I also now have the experience of such a busy level 1 trauma center that's it's kind of crazy how busy this place can get, and seeing all the different cultures and how each patient presents, it's pretty nuts.
So give me a little perspective, because we ask everybody this, and I think it's no surprise or no secret for our listening audience that I'm not a fan of the insurance companies, and I'm not a fan of hospital administrators, right?
Sure.
So we say that quite a bit.
Yeah.
So give me your perspective on the American healthcare system, given what you've seen in the ER, and particularly in a big, level 1 trauma ER in Brooklyn.
So the American health system is, like everybody says, so broken.
Yeah.
And we are basically a safe harbor for so many people that are of low socioeconomic status, undocumented immigrants. We're basically a critical access hospital for all of these people.
I see.
And we see a majority of our patients, I would say, are Medicare, Medicaid, or no insurance.
Yeah.
And to see these people coming in for even like primary care things, like they don't have primary care doctors. They don't have that kind of follow-up. They'll be switching insurance. They'll be saying, "Oh, I'm with a job center right now, trying to find how I can get food on the table for my family." I've had patients leave against medical advice because they need to go pick up their son or daughter or put food on the table for them, and they may have a serious problem. So it's really interesting because our hospital is so overwhelmed with how many people are in this city and that need medical care, that it takes months to get a primary care follow-up visit, unless you're going to, our primary care clinic.
Right.
We have pretty quick follow-up for that, and we offer free visits on the first visit out after leaving the ER.
Okay.
So whatever specialty we have, which is really nice.
And how does that get paid for? Is that grants? Is that federal?
So a lot of it's
that?
federal funding,
Yeah.
and I don't know too much of the details of the finances of our hospital, but in general, we do see a very low socioeconomic status patient population.
So given that, from your perspective, are there any fixes, easy fixes or hard fixes to the issues with healthcare now?
We need more people to go into primary care. I think that's like the biggest thing. If we can have good primary care docs, good primary care APPs, and you're doing all this preventative medicine, you're keeping these people from coming to the ER.
Within the inner city.
Within the inner city, well, yeah.
Everywhere, really.
Exactly,
I mean, how hard
everywhere.
is it for us in South Bend, Indiana to find a primary care physician?
I mean, we have primary care docs, though.
But it's hard to get in.
It's hard to
right?
get in. That's the problem.
Yeah, because everybody's like, well, referral only, or
Uh-huh.
if they want to see patients,
Yep.
I guess. Is it the same here, or is it just a sheer number of people who it's like an outnumbered kind of situation where there's not enough docs?
I think it's a combination of the two, and I think hospitals, no matter what they say, because a lot of hospitals will say, we're not relying on residents and that kind of stuff, but in New York City, you have to be. I mean, I don't understand how some of these hospitals would run otherwise. Which honestly, it makes it a great place for training. I think our residents get fantastic training at our emergency department. A lot of crazy traumas, a lot of super sick people. And again, I think that's because, they don't have access to the providers that they need. And I don't know how that's going to get solved.
So I've been in it long enough. I saw a big shift basically with the financial crisis of 2008, 2009. So before that, the patients who came into the hospital were sick, but not as sick, and a lot more of them were seeking primary care. And then after that 2008, 2009 financial crisis, our ICUs were packed, ERs were packed, operating rooms were doing stuff that had they seen a primary care physician and got it taken care of, they wouldn't have come into the operating room. So, I mean, I think that was the initial spiral, and whatever you think politically, I don't think the ACA helped. I think it actually made things worse, primarily on the doctor end of things, because nobody wanted to do primary care because there was no incentive for it anymore. And then, we've got the most recent, the COVID crisis, and a lot of people retiring, and now we have a big
there was a huge
shortfall.
Exodus.
Yeah,
huge exodus.
Big shortfall.
In medicine. I totally agree with you. The 2008 financial crisis was, it was a crisis, right? So not only did financial institutions and the housing market and all these other things suffer, but medicine suffered.
Oh, yeah.
And it's really interesting to think this way. I actually read an article yesterday. It's like an opinion piece by this ER doc. He writes really great articles. But one of them...
Who is it?
Edward Leap is his name.
All right.
L-E-A-P.
There's a guy in Indianapolis that I actually trained. I was a medical student when he was an ER doc. Oh, man, I'll think of his name. But he writes a bunch of articles.
There's a lot of ER docs that have this like passion for literature, which is really, really, really cool. But this guy, he wrote this article, and he basically talked about how it's a dark thought, but our technological advances have gotten so good now, and our medications have gotten so good that patients that, 40 years ago, if they had, let's say, pneumonia at the end of their life, they would die, right? And now we are continuing to just see these same patients coming back in with recurrent pneumonia or, some sort of malignant tumor blocking a bronchus or something, causing this recurrent pneumonia. And it's interesting because you hear that and you're like, yeah, there are people living a lot longer than they should be. Now we have LVADs and all these other things that are artificial organs, basically keeping people alive. So hospitals are going to be overwhelmed, and that's just the truth.
Yeah.
And then the boarding crisis in the ER has been horrible since COVID.
So talk a little bit about that, just real quick, if you can talk about what that means.
Yeah. So the boarding crisis is basically patients who get admitted to the hospital. They stay in the ER
because there's no beds on the floors.
Because there are no beds on the floors, and then the internal medicine people have to come down and round on them in the ER. This leads to increased morbidity, mortality when these patients are not being monitored.
Yep.
And then these nurses, these ER nurses, they have like 7, 8 patients and the docs like, we already admitted the patient.
You're
like,
done.
This person's been here for 2 days, and I've already changed shifts twice.
Yeah.
And you're like, what am I going to do to solve this problem?
Yeah, nothing.
Yeah.
What were you going to ask?
I was going to ask, this is a follow-up on what you guys were talking about. You started to go into a question that we ask everybody on this podcast, and that's the future of medicine. But I'm particularly interested in your answer because you two are at such different points of your career, I think. It's not just the different path that you both took, but you're a little younger. You're kind of more fresh out of school. You've been in the industry for a long time. Your perspectives may differ here. So what is your take on the future of medicine? Where do you think it's headed? And how do you think all these people that are going into these ORs with really nowhere else to go? ER, I'm sorry. What is your take on that?
So it's not going to get better until it gets worse. And I think something's got to give. Something's going to happen. I don't know what's going to happen, but the next crisis that we have, the next COVID, could be the thing that breaks the back of modern healthcare. I think the only way to solve this problem, again, is to start with solid primary care and having more people not enticed to go into primary care, but I think they're trying to
see the value
to see the value of it, because there are not many people going into it anymore, and it's really sad.
Yeah. So a couple of things. So I started medical school in the early 2000s, so I have a little different perspective.
Sure.
They've been saying that since I applied to medical school.
Wow.
In the
saying what?
Saying that the system's going to break. We're at the point it's going to break. It's going to break.
And what is excuse this, because I'm the layperson here. So
the only doctor not on the show, right?
That's right.
Or only not doctor on the show.
Correct. When you say the medical system will break, what does that officially mean? What does that mean in terms of breaking?
Patients won't be able to get care.
Yeah. I think, honestly, it might already be broken.
Well,
isn't 90% of the world not receiving care at this point? Or the care they need?
Yeah, in foreign countries for sure. The socialized medicine countries is a delay in care, but not necessarily an access to care issue. But yeah, most of even the developed world, unless you've got cash in hand, you're not going to see a physician.
Yep.
They won't let you in the hospital.
Yeah.
I think it was I read an article about the Philippines, where in the Philippines you have to walk up with whatever, 10 grand or however much money for them to let you in the ER to be seen, to figure out what's going on.
That's crazy.
So you have access to care. You just can't afford it. Is this where we're headed? Like, we have access to care, but unless we have money, 10,000 whatever in hand, we can't get it? Again, without being political.
Yeah, I think it's going to be even more of an access issue. There's access now. Now, I don't believe that there is a complete lack of access, because there's an ER almost everywhere.
Yep.
And if you,
it's just going to take a long time to be seen.
If you have a medical issue in any ER, any state in this country, you walk into the ER, you have to be seen.
Yes.
It's a federal law. So fine. I think right now there's access, but at some point there will not be physicians or even mid-levels, APPs, to be able to see you.
Yep.
So at some point you're going to walk into that ER and they're going to say, hey, you can sit in this bay over here, but it's going to be 3 days before anybody sees you.
Yeah.
So that's what I think eventually is going to happen if something doesn't change.
Yeah. I totally agree with that too. And I think the scary part of that is that, whoever's coming in with, I guess if it's like chest pain or something like that, sure, you're seen quicker. But if it's someone who's coming in with vague symptoms and then they just, drop dead right there and no one's seen them yet, that kind of stuff has been happening over the past several years, especially after COVID. COVID completely caused a mass exodus of a lot of physicians, a lot of nurses, a lot of APPs. and caused people to go into other areas.
Yeah. I mean, if you're making, again, not to be political, but if you're making $30 an hour at Target and you're making $32 an hour as a nurse in the ER, what are you going to do?
Exactly.
I mean, you're going to go to Target because why would you want all that stress of being an ER nurse? Just go work at Target, make almost the same money, and there's no stress. Oops, I didn't put the right thing on the shelf.
Yep.
Oh,
exactly.
well.
Whereas, if you scan the wrong medication, you're getting a nasty email from
or kill somebody.
Or kill
even.
somebody.
Yeah, not intentionally, obviously, but
Yes.
So I mean, I don't know what the overall answer is. I mean, what we talk about in terms of surgery, because a lot of surgery is elective, and even somewhat urgent, probably not emergent surgery, but urgent surgery is creating direct to employer, direct to consumer, getting insurance out of the way, right? So I mean, there's nothing. Again, no secret. We don't like insurance companies, and I'll say that on basically every show.
Totally.
So if we get the insurance companies out of the way, I think you improve access, you improve reimbursement, you improve cost. Everything improves if the insurance companies are out of the way. How do we do that in the ER with people who already don't have insurance? How do we fix that problem?
So I agree with your sentiment about not really liking our insurance companies, and I think a lot of that unfortunately has to be dealt with in the political realm.
Yeah,
and we have a lot of these lobbyists that are lobbying our congressmen and congresswomen to
against the interests of the healthcare industry.
Exactly, and it's money talks, and what's going to happen is these companies that have billions and billions and billions of dollars, they're throwing it at these PACs for different Congress people. Whatever side you're on, I think there's a lot of smoke and mirrors with it, and I think if that doesn't change, healthcare is not going to change. And in our hospitals, when we have patients without insurance, a lot of that is they're in between jobs, or maybe they suffer
applied
from
for Medicaid,
exactly,
or whatever,
or they suffer from some substance use disorder or whatnot. Those people will continue to add to the deficit of hospitals, and unfortunately, the government's not paying nearly as much as they should for those patients. And that leads to hospitals closing. Yeah. We've had a few hospitals in Brooklyn close this year. Yeah. And that's scary, because now where do these patients go?
To you.
They come to our hospital.
Exactly.
And then we become more overwhelmed. We get more uninsured patients. Government's not reimbursing us, and then we're not,
financially viable.
So
exactly.
What's happening in Canada then?
They have socialized medicine. It's all run by the government. But there's a two-tier system in Canada, right? So everybody, you're a Canadian citizen, you have their basic health care. Now you're going to have to wait a year or 2 years to get your knee replaced, or, you got a little knee injury, right? Even get your knee looked at might be 3-4 months.
Is that where we're headed?
I mean, that's a good question. Let me finish the Canada thing, though. So the other side of the Canadian system is, if you have cash, there's a whole group of physicians and medical professionals who take the cash. So you say, hey, I know you can't
privatized.
Right. I know you can't get in to see the government doc, but if you come to me with a couple $100, I'd be happy to evaluate your knee.
Sure.
Tomorrow.
Interesting.
Isn't there kind of a growing population in the United States for that kind of care?
Oh, yeah. Yeah, direct primary care, direct physician care.
Concierge medicine.
Yeah. Concierge medicine.
It's huge,
Yeah.
It's just really interesting to think about. I mean, depending on where our healthcare system goes, I mean, is that going to be the future? I mean, you walk in. We were talking about it last night with drip bags.
Yeah.
Oh, yeah.
Yeah, IVs. Yeah.
Those who want to get the medication, feel better, go out drinking, come back and they get the IV bag. They have $500. You lay the $500 on the table and you get the care.
Yep.
Is this where medicine is going?
I mean, some of it, not for emergency medicine.
Not for emergency
I don't know how you do that
So-
for emergency medicine. Yeah.
So it's really interesting. I had a colleague who had this idea, and he wanted to create private ERs. So if you needed to be seen right away, you wanted a CAT scan right away, you come in. But they wouldn't get reimbursed by Medicare, Medicaid.
Right. You'd have to be outside the government system.
Exactly.
Otherwise, you're
Otherwise, it's EMTALA
Yeah, you're an EMTALA violation.
Exactly.
EMTALA it was a law, 1986, I believe, that the Reagan administration passed that if you come to an ER, you have to be seen. Doesn't
you need
matter.
a medical screening exam.
Yep.
And that could mean getting vital signs and having me look at you, or it could mean, doing a full exam.
Pan scan, everything.
Exactly.
Yeah.
So there are a lot of patients that, we have a lot of malingering in our ERs, which malingering means doing something for secondary gain.
Yeah.
So basically showing up and being like, can I get a sandwich?
Yeah.
Or,
I'm cold.
I'm cold.
Yeah.
Sure. Like that. So there's a lot of malingering that goes on. And with that, you will have patients that get upset. You didn't even look at me. You didn't even do a physical exam. And I'm like, well, actually I did.
Yeah.
I could tell how fast you're breathing right now by looking at you.
I can see it from, I
Your
can hear it
eyes
from
are
the
moving
door.
around.
Yeah.
Neurologically you're intact. So, it's interesting.
Out of curiosity, what was your experience like making rounds in Grenada? What was that like? I mean, did you have
was that
experience of
different? Yeah.
that? Was that
Yeah.
That's a good point.
So,
did it at all get you ready for what you would face in Brooklyn? Probably not, but
So actually, we do 2 years down there, and then we do 2 years of clinical rotations.
Oh, so you don't
here.
do the clinical
okay.
stuff down there
So
at
we,
all?
So we do.
Yeah.
So we do, which is really interesting. We go in the hospital, Grenada General Hospital. We do.
Like internal medicine, probably,
Yeah,
right?
yeah. Well, you do like that, and you can go to different specialties, whatever you're interested in. You can kind of walk around with some of the physicians there. A lot of alumni come back and volunteer their time at the hospital too, which is pretty cool. But my third year, I was in New Jersey for all my third year rotation, and then fourth year, I did some New Jersey, New York, and Florida. Okay. So that was all my clinical stuff. So I had a good exposure to different hospitals, different sites, whether that's a level 1 trauma center or a community hospital. Yeah. But Grenada was really interesting. Grenada General, all of the wards were open to air.
Wow.
So no
That's
closed
cool.
windows.
Wow.
It was really interesting. All the ORs were also in that area as
Wow.
well. So like they would lead to a hallway and go right into the OR.
Interesting.
But it's not a first world country.
Yeah.
So they do lack a lot of the resources that a hospital would need, and they have a lot of older equipment. So it was interesting seeing that for the first time as a medical student and being like, "Oh, this is normal." And then you come
you
to
show up
America and you're like, "Whoa,
Yeah.
this is crazy."
So do you think, and I'll just broach the issue here of two things. One, APPs. Do you think as because in anesthesia, it's moving more towards CRNAs,
Sure.
right? And we as anesthesiologists are more kind of in the background, maybe overseeing a lot of CRNAs, doing pre-op and PACU, that sort of stuff. Do you think that there is a place for just basically turning over a lot of primary care to advanced practice practitioners, number one? And number two, what do you see the role of AI in emergency medicine and in primary care? I mean, those are two, I think, big things that
Huge
people
topics.
kind of pushing.
Throw internet in there too, like AI/internet.
Yeah,
'cause
yeah.
I was
Yeah,
curious
yeah,
about
yeah.
that too.
Yeah. So APPs in primary care, I think it's a good thing and a bad thing, right? So I think we have advanced practitioners who their training varies, right? So PAs get the same training, right? They have the 2 to 3 years, or I think it's 2 years of school, and during that they do their clinical rotations. It's very similar to medical school, but very truncated.
Yeah.
Okay. So their care is standardized across. NPs is where we're getting a little bit of that gray zone, where some NPs were nurses for 25 years in the cardiac ICU,
Yeah.
right? And they've done a lot of cool stuff. They've seen a lot of cool stuff. And then they go to NP school.
Yeah.
But now there's this new cohort of nurses who are
Straight into
21 years old, going right into NP school, not doing any clinical
Yeah.
work. And you're like, how on earth can you be prepared to take care of patients when you've never done it?
especially sick patients. Yeah.
Especially sick patients. And then, some of these NP schools are online, and then it's like, okay, now we're like muddying the waters, and this seems more like a money grab as opposed to actually worrying about patient care. So APPs at primary care, I'm sure there are fantastic ones, and I'm sure there are really bad ones, because we get patients that are referred to the ER all the time
Yeah.
by primary care centers that are run by an APP, or, hey, my so-and-so sent me to the ER to get this checked out. They said my EKG looked weird.
Yeah.
And I'm looking at it and I'm like, that's benign early repole. Like,
Right. Yeah, I
they're
love
like,
those.
you're telling me I wasted my time coming here? I'm like, I'm sorry, but like, I'm just giving you reassurance.
You
That's all
don't
I
have a
can do.
cardiac issue. I get those all the time.
Yeah.
So just a little behind the curtain. When we get an EKG, there's an automatic read on the machine.
The computer, yeah.
And the machine is made to overread everything. So it wants to detect everything. So to do that, it has to make sure that it overreads. It might say, yours might be almost perfect and there's one little thing wrong, and it'll read it as very possibly could be early repolarization.
Yeah.
Which, if it's true, might be some sort of cardiac issue, but almost never is it true on that read. And so you have to, and I do this too because I look at the charts before they come to the operating room. You have to be able to read that EKG and say, yeah, I know the machine said is early repolarization, but that's not. This is a totally normal benign EKG.
Absolutely.
So I think there's a lack. I mean, honestly, there's a lack even of the primary care physicians in
100%.
an ability to do that. A lot of them will see that read and just send it along. So, I mean, I know you do some education stuff on radiology, but I think EKG would be awesome. Yeah.
I love ECGs. I love them. There are some absolutely fantastic emergency medicine educators out there. One of my heroes is this guy named Amal Matu, and he does this website. It's called ecgweekly.com.
Okay.
And what happens is every week he sends you an email with a new case going over some sort of pathology on an EKG that is relevant to emergency medicine. And I've been doing that since fourth year of medical school.
Nice.
And I love that stuff. And surprisingly, there are a lot of emergency medicine people that don't feel comfortable with EKGs.
Yeah.
And that's something we see every shift, probably 50, 60 times.
Oh, at least,
right?
yeah, right.
Because they're constantly, the techs are constantly handing us EKGs and interrupting us when we're doing other stuff. Hey, can you sign this?
Yeah.
To make sure it's not a STEMI or complete
Yes.
heart block or something like that.
So for me, it's dangerous or not dangerous, right? I don't have to make the call of what to do next. I just have to say that patient can come to the
Should not
operating
go to the
room
OR.
versus they can. So for me, I've got it down pretty well, and I'm not perfect, obviously, but I've got it down pretty well where I can look at the EKG and say, yeah, that patient should be fine, or that patient needs further workup.
Exactly.
So it's a little bit different for us, but yeah, I mean, being able to effectively read at least scary versus not scary on an EKG is like critical.
Yeah.
If you're doing basically any area of medicine.
And it's one of those things where it starts to get to a pattern recognition thing where you see so many EKGs over so much time where you're like, all right, I don't know what's going on there. That doesn't look right.
Yeah, call cardiology.
Exactly.
Or, get them out of the ER, get them up to the cardiac floor. Yeah.
Exactly. So that's interesting with the APP kind of question. Like, I definitely think we need more primary care people. So unfortunately, until we figure out a better way to get good docs into primary care and entice them to go into primary care, then, that's going to have to be the fix.
The APPs,
which I don't know if that's the best fix over time.
So just quickly, what about AI?
So AI, it's funny you talk about ECGs, but AI is, there's actually an AI chatbot that's made to accurately give diagnoses on ECGs that are actually very spot on.
Are they?
Like,
that's
scary.
That's cool.
There's also rash ones where you take a picture of a rash and it will give you. It's
hated dermatology.
Well, I mean,
yeah, you got to see it though.
We
Yeah,
weird rashes all the time, and I'm like, I have no idea
Yeah.
what this is. And then derm, if they answer the phone, they'll say, oh yeah, just give them steroids, they'll be fine.
If it's wet, dry it. If it's dry, wet it, and never touch it. That's all I remember from dermatology.
And that's perfect. My fiance will kill me for saying this stuff. She's a cosmetic derm PA,
nice.
Which she loves. But so AI is slowly working its way into education or into helping us screen for certain things. In terms of AI in the future in emergency medicine, I think it's going to be, there's no longer going to be scribes, right? I think AI is going to be able to listen. It's going to listen into my conversation with the patient and document an entire thing. We already have that. That's starting to be developed. It's starting to be used more, which, I mean, God bless. That would be awesome because I hate charting more than anything. And all our charts need to be like
perfect.
under lock and key, like because they will be scrutinized in the court of law and be like, doctor, you spelled this word wrong. That means you're careless and you don't care about your patients. And that's why this happened. And I'm like, what? So thankfully I haven't been in a lawsuit or anything yet, but at some point I will
You
be.
will be,
because I am the first contact in the hospital.
Statistically, you will be.
No matter what happens in the ER, if something bad happens later in the hospital, I will get brought into a lawsuit.
So I remembered that doc's name, Lou Profeta. Does that sound familiar to you at all? He's an EM doc in Indianapolis, but he's all over like Doximity and all that stuff.
Oh, cool.
All right, so the other question we ask everybody who comes on,
Sure.
Would you do it again? Now, you're pretty early in your career.
I was about to say,
would you do it again?
I think I absolutely would. And the reason why I say that is because obviously I'm very early in my career. But I've experienced so many things in the emergency department and on the road to emergency medicine. And I've met so many incredible people, incredible educators that are very passionate about what they do. And that kind of passion, just seeing that kind of reaffirms that I'm in the right specialty. And honestly, some of the sickest patients I see, getting them back from the brink of death or, finding that thing that's been bothering them for so long. Some of these people are so thankful.
Yeah, rewarding for sure.
And it is very rewarding. And they may not remember who you are or, your name at the end of the day because you're just that ER doc.
Right.
Because you don't follow these people, right?
Yeah, same. I mean, it's
exactly. So they'll always remember like what you did. They may not remember who you are.
Yeah, that's fair.
So that's actually something that keeps me going, which is nice.
That's awesome. Yeah. What this is a little tongue in cheek, but going back to the AI really quickly.
Sure.
What percentage of patients, and maybe more so with you than you, what percentage of patients come in and are like,
Google? Yeah.
Hey, I Googled this like 32 symptom list.
95%.
Really?
Oh,
wow.
Yeah. Oh, yeah. Every
and you hear everything.
Yeah. Well, so every patient prefaces it by, I've been having this going on for a while. Some patients will come in for a problem that's been going on for months.
Usually at 2 a.m.
Why are you here? Like what?
Then it hurts to the point that they have to come in now.
So my questions turned into not why are you here? Why are you here right now?
Yeah.
Like what brought you in right now?
Google.
Please stop telling me about 5-6 months ago, 7 years ago when you got into a car
Tell me what happened
crash.
tonight. Yeah.
What brought you in? So a lot of these patients will say, I was looking up my symptoms on Google, or I looked up my symptoms on ChatGPT and it told me I could be having a heart attack. And I'm like,
but wouldn't you rather them check than not?
No,
because I think this turns into a vicious cycle.
It's a self-fulfilling prophecy.
They came in.
Yeah, but
I mean, so I guess what I'm saying is
their insurance gets billed 10 times more because they're coming to the ER. This is an emergency visit.
Yeah.
So if I have our Russian population in Brooklyn, they have an obsession with their blood pressure.
Okay.
And people come in all the time for elevated blood pressures, 180s, systolic, even 200 sometimes, and then we'll repeat it and it's fine. But asymptomatic hypertension, the American College of Emergency Physicians, they stand by that if a patient has asymptomatic hypertension, there is nothing we should be doing because you might be causing, more morbidity and mortality
by dropping their pressure too quick.
Because you don't want them to stroke.
And you're not going to follow up. I mean, if you give them a script for amlodipine for a month, and then they stop and they get rebound hypertension.
Exactly, which you don't want. So when these patients come in and they're so worried, a lot of my job is reassurance.
Yeah.
So I think the reassurance is fine. And I think if you're worried about something enough to the point of going to the ER, then sure, come in. We'll check you out. You might just wait for a little while. If you're having chest pain or something, you're going to get an EKG under 10 minutes. Like that's going to happen. So you'll know, or someone will know if you're having a heart attack. But
so the biggest thing we had, and we can end with this, but the biggest thing we had in the Hispanic population in Indianapolis was they would come in and complain of young women abdominal pain because they wanted a pregnancy test. Because culturally they believed that the pregnancy test you got at the hospital was better than the $1 test on the shelf. And then as soon as they got the pregnancy test back, they'd say, "My stomach's better. I'm signing out."
Yep. So spoiler alert, it's not any better. It's literally the same thing as your pee on a stick test.
Yeah, it's exactly the same.
The exact same. So guys, if you take anything from this podcast,
Pee on a stick.
pee on a stick. Don't
you
come
got
to the
from
ER.
Walgreens.
Yeah, don't come to the ER.
Don't come to the ER. If you are having abdominal pain and like for real abdominal pain and you know you're pregnant, yes, come to the ER. But otherwise, if you're coming in for a pregnancy test, we are no better than an urgent care. We are no better than your local Walgreens or CVS.
Chris?
And let me point out that, and we say this on every show, we are both doctors, but we are not your doctor. So if you're having any medical issues,
100%.
go to your doctor.
He might be hundreds of people's doctors.
right.
Or the ER.
Yes.
Or actually go to your urgent care first, then your ER.
Or your primary care. Give him a call.
Primary care, yeah.
Maybe talk to your primary care doctor. That'd
If
be
you
great.
can find one.
Yes.
If
No
you can
kidding.
get in and
Sad.
if you can find one.
Dark.
Chris, before we wrap up, I just want to give you a chance to talk about your new podcast. I think you have I don't know if it's how long you've been doing that podcast for?
So initially I had a podcast called Res Life, which is more for pre-meds and med students to give them advice. It's on all streaming platforms. We stopped, me and my buddy, who's a neurosurgery resident right now, we stopped doing that probably a year ago, and I got more involved with EMRAcast, which is a podcast put on by the Emergency Medicine Residency Association. Fantastic podcast. Myself and a bunch of co-hosts did that. And then I actually just started doing some podcasts for a company called MRAP, which is the Emergency Medicine Reviews and Perspectives. And they are,
Education stuff, yeah.
It's all education. For myself personally, my partner and I, Dr. Gary Cook, we just started a radiology education website with video, like a podcast style video review series with lectures, basically teaching radiology for the non-radiologists. So if you're interested in that, you can check out rapidradsmeded.com. Fantastic resource. We've spent so much time on this, so much time and effort, and we're so excited that it's finally there. So
That's awesome. Cool. And what about social media? Where can people find you on social?
So I'm on Instagram, TikTok. I am not on YouTube yet. Thinking about it. But you can follow me at Doc Riles, which is DocReilles.
Nice.
We need to hear a jam session at some point with the guitar, by the way.
Heck yeah.
Might need to get that and take it to, we're going to Dumbo after this.
Yeah.
So, which is a neighborhood. And
Yeah.
Brian was asking, why is it called Dumbo?
all I'm
Is it
thinking
short
is the
for
flying
something or is it?
I think it's it's an acronym for something.
Okay.
It's like something under bridge. Oh, I forget what the action. I'm gonna have to look this up.
All right.
Yeah.
Let's tell our listeners.
All right.
So
What does Dumbo stand for?
What does Dumbo stand for?
So on all the platforms, Facebook, Instagram, and TikTok, and then follow your podcast at those two sites.
for
Okay,
sure.
cool, nice.
All right.
And we'll obviously link it below too.
Yeah.
So,
Drum roll.
all right. Dumbo stands for?
Down under the Manhattan Bridge overpass.
Wow. Okay.
Yeah. Dumbo.
All I can
Perfect.
think of is the flying elephant.
Say that
Yeah.
10 times.
Yeah, exactly.
Down under the
Down
Manhattan Bridge overpass.
Yes.
Wow.
We should just refer it to that only now.
Yeah.
No longer Dumbo.
Dr. Chris Reilly, thank you so much, my friend. And I know, look for more collaborations between these two. We're about to go to down under the Manhattan Bridge overpass to film that
It
content.
sounds seedy. Like it sounds
does.
like
Yeah.
we're going under the underpass.
Yeah.
Under the overpass.
All right. Thanks so much for joining us, Dr. Reilly. Thanks so much.
Thanks for having me.
Dr. Schmutzler, it's always a pleasure.
As always.
We're signing off from Brooklyn. We'll see you in the next episode.